What is communication in ophthalmology? My name is Lorcan Butler. I'm from the IV's podcast from iNews magazine. Thanks to the sponsors of the show, Mainline Instruments. They provide unmatched service and unbeatable products in eye care technology. But just a reminder, this podcast is editorially independent. So happy to be joined by Gok Ratnarajan today. Gok, for people who don't know who you are, could you please explain where you're from, what you're doing?
Lorcan, thank you very much for the invitation to be on the show today. I am head of glaucoma at Queen Victoria Hospital and also co-founder of the U Clinic.
We're going to talk about communication in ophthalmology. So the communication among staff, communication among colleagues, communication with our patients. Because sometimes communication can be very, very good, but sometimes communication can be very, very bad too as well. Can you tell me where your background, your training communication, where your experience comes from?
Yeah, I think this is a topic dear to my heart. Communication is the cornerstone of what we do. We are in the business of people. Helping people, dealing with people, helping people through their health journey, their eye health journey. So, you asked the question about where did you get your training from? You don't really. I look back at medical school days. I went to UCL, had a great training at UCL. And of course, as part of that training, the first few years, you're really learning your basics about the human body and how the human body works. And then you get exposed to patients. And you do have some basic communication skills, but it doesn't really set you up for the real world.
No, it doesn't. Yeah.
I remember going onto the ward for the first time. I think I was doing a gastroenterology job. And, I was petrified at the thought of just talking to a patient. And these are patients that are ill, some of them very ill, and it was scary.
Yeah. And was communication a part of your curriculum when you were in college?
It was a softer skill.
Yeah.
It wasn't something that you were going to pass or fail on, but something that you had some basics, introduce yourself, ask for consent, and then when you're leaving, certain ways of doing things, but not a sort of strategic way of broaching conversations. We do get a session on how to break bad news.
Yeah.
Again, that varies.
It's a difficult conversation to have at any time, isn't it?
Yeah. I remember in my group, there were some people that really struggled with it. Other people that got so nervous that they started smiling. It's a human response to something that is so out your comfort zone that you sometimes have this incredible response. Like, why am I smiling when I'm telling someone that they may have a life-changing condition? And it's not because they're obviously happy, but it's just that they're not used to it. I think over time, you get better at it. It's never easy breaking bad news. I'm a glaucoma specialist. That is a chronic condition. Once you are diagnosed with glaucoma, you have that for life. At present, despite all the innovations, it's a condition that we can't improve. So it's all about trying to prevent further vision loss. And it has real connotations for quality of life, an area that I'm hugely passionate about, the ability to drive. Breaking bad news is something that I do on a weekly, if not daily occurrence, unfortunately.
Going back to your first appointment with your patient when you do give them the diagnosis, how do you frame that to make sure that they come away with a positive outcome rather than a negative outcome?
I think you have to be clear. So, there's no point skirting around the issue. They need to understand that they have the condition. So, after I see them, examine them, talk through their tests, I say, your optic nerve is showing some signs of damage, and that's a condition called glaucoma. And unfortunately, with glaucoma, once you have glaucoma, we can't reverse it. But the key thing is early diagnosis. And thankfully, where I work, the optometrists are very good at picking things up. So in the vast majority of consultations, it's letting patients know that they have a condition, but it's caught early. I let that settle in, but then I very quickly switch the tack to the positives.
Yeah.
Because otherwise their brain just shuts down and they leave the consultation with nothing but, I've got a condition and I'm going to go blind. So then I say, look, we're very fortunate now in modern treatments. And this is, the exact phrase that I use. We control glaucoma. Glaucoma doesn't control us. And I'm very careful to use the word we, so they don't feel that they are going through this alone. They feel that they are protected, they are seen by their consultant, the wider team, and they are going to go through that journey. And I think they feel reassured that knowing that things can be done, and the prognosis for the vast majority is very, very good.
One thing I wanted to ask you too as well is I like the way you chose condition rather than the word disease. Is this something that you do regularly? Because we tend to find within kind of ophthalmology, optometry, we talk about dry eye disease. We talk about myopia being a disease. When it comes to glaucoma, do you frame that as a condition or a disease?
Yeah, I think that's a good point. It's maybe something that's subliminal. I haven't quite realized, and you brought it up there. I think the word condition is a softer term. It's not to belittle the condition, but disease has a real negative connotation, and I think there's no point bringing extra negativity around an already difficult situation. So yeah, something that I haven't really thought about, but yeah, you make a good point, Lorcan.
So we're moving on to our treatment. So we're going to recommend our primary treatment option for our glaucoma patients. How do you set them up? What would you say would be a successful outcome?
You don't want to over bombard with information. So I sort of say, there are three options. Option one is to do nothing. And option two is to think about a laser treatment called SLT and talk a little bit about the great evidence we have around that, particularly with the light study. And then option three, drops. The vast majority go for laser. I explain how it's safe and non-invasive, and overall the chance of a good reaction or outcome from the laser is high. Some patients get nervous about that and that they think about it as some sort of procedure. I make it clear that it's not an operation. For my very anxious patients, I'll walk them across to the laser room and show them that, it's the machine like the slit lamp, and there's no knives or anything like that. But you have the minority now that say, oh, I'm okay with drops, or yes, there was a family history of glaucoma and my mother or my father or my brother is putting drops in and I'm quite happy with that. And that's fine. Of course, it's the patient choice, but it's our job to give them all the options and then help guide them to what is the best choice for them. And that's my sort of operator's modus of practicing, to empower the patients and then ultimately let them make the choice.
And in terms of doing the treatment and then maybe it's not successful, how do you have that difficult conversation with the patient?
Yeah, it is rare, but again, good communication beforehand, letting them know that there is a small minority that either have very little or no response to SLT or a short-lived response. So in that scenario, they are aware that that could be an eventuality of the treatment, and therefore, though disappointing, it's not something that they are not potentially ready for.
If you move away from the patient scenario for a moment and let's talk about your inner team and the team you work with, your multidisciplinary team in hospital or in private practice, how do you go about communication with your team there?
Yeah, it's so important. I think we're really fortunate at Queen Victoria and at the U Clinic that we have a really cohesive team. Ultimately, as the consultant, you are the leader of that clinical team. And that comes with great responsibility. I'm a big believer in leading by example. So it's, do as I do, not as I say. I believe in a flat hierarchical system that the most junior member of the team should be able to voice his or her concern to the most senior member of the team. I have a very open door policy. I set my expectations. I have high expectations, both in terms of clinical practice and my research, and I expect a certain work ethic and ethos, and those things are non-negotiable. But I think I would hope that my team would say that I'm someone that is approachable and they can come to with any concerns.
So do you perform any communication training for your team?
Not specifically. I think generally when it comes to hiring the team, as part of the selection process and the interview process, you sort of gauge who are good communicators, both within the team and obviously to your patients as well. So nothing formal there, but I think certainly for me, one of the key things that I'm looking when I'm hiring people is, can they communicate with the team and with the patients?
Yeah, and it's very important too as well to be able to communicate in non-clinical terms. As clinicians, we tend to discuss among ourselves, among our peers, or clinically, but it's very important to be able to then turn immediately to the patient and speak in kind of layman's terms too as well. Do you find that difficult?
I'm trying to think back to when I started, and probably it was more difficult then. Having had a few years under my belt now, and a few more grey hairs on my head, I think it does come a bit more naturally to me. I think I'm quite an empathetic person. I do feel that I can put myself in the shoes of my patients. So I think, and my colleagues and team may say otherwise, but I think that I'm quite good at explaining things in non-medical jargon.
Time for a word from our sponsors, Mainline Instrument, leading in ophthalmic innovation since 1997. Mainline Instrument supplies premium ophthalmology equipment from global manufacturers, including iCare, Oculus, Tord Pi, Tomei, Optomed, Huvitz, and Neats. From advanced diagnostics to surgical solutions, explore their products and services or book your in-clinic demonstration at mainline.co.uk. Mainline Instruments, unmatched service, unbeatable products, unrivaled quality.
So I'm going to ask you a difficult question. How can you show empathy to a patient who maybe is anxious or nervous or maybe not as happy with the results of a test that didn't go as well as they expected?
You would hope that people going into the medical and healthcare profession are empathetic by nature. And of course, that's not always the case. So if I maybe rephrase that question slightly and talk about cataract surgery and patients that have a less than ideal outcome from cataract surgery, that is one of the hardest conversations we have. Cataract surgery is one of, if not the most commonly performed operation in the UK. Everyone knows someone that's had cataract surgery and had a great outcome. And each patient is individual. And I mentioned that on in various talks. We have such a wide group of patients, so there is no guarantees with cataract surgery. And I think again, communicating the risks before the surgery, albeit small, but they do need to understand that it's not a slam dunk. And with anything in medicine, things can not go to plan or have complications. And then it's sort of sitting down and working with that patient to say, what is it about your vision that you're not happy with? And then trying to come up with a solution. If something is wrong, how do we correct that? Or if it's the patient expectations are out of sync with, or they have unrealistic expectations, and that's difficult.
Yeah, let's highlight those unrealistic, outcomes and unrealistic kind of ideas that they want. Could you give me a couple of examples?
Yeah, I think if we talk about, say, a private cataract patient, again, the most important part of that journey is not the surgery. That's the most predictable part. It's the consultation. So one of my passions and things that I like to talk about is defining perfect vision. Lorcan, what you may think is perfect vision, what I think is perfect vision, what our listeners think is perfect vision is so individual. If you're a golfer versus someone that's, an avid sower, it's very different. So people cataract surgery is an opportunity. That's what I tell them. It's an opportunity to reset your vision to what you want it to be. So your neighbor may have come away and had a very good outcome, but he or she may play golf 4 times a week. So because they'll often come and say, oh, so-and-so had this type of lens. I want that type of lens.
Yeah.
And I said, okay, look, I'm not saying it's off the cards, but let's understand your visual requirements, and then spending some time to take a good social history. Then you marry that in with the science and sort of say, okay, there are these different types of lenses: a distance lens, a near lens, a distance and intermediate, a extended depth of focus, a trifocal. It can get overwhelming, the amount of technology we have.
Yeah.
So it's that fine balance between empowering and informing our patients, but not engulfing them with information that it just goes in one ear out the other. And then I would say in the vast, vast majority, once you present that information, they will then say, yep, I want that type of lens. And then it's important.
It's driven by them then.
Exactly.
Yeah.
But then it's important to reiterate, by doing this type of lens, you may not get great near vision in dim lighting, for example. So if that were to happen in the post-op scenario, you've clearly had that conversation. It's important to also document that clearly in your letters.
Yeah.
And patients will sometimes pick up on the letter. You said, "Oh, I will say, that we've chosen a lens to give X, Y, and Z, but you may need spectacles for this." And then they may ring and say, "Oh, you did." I said, "We did." And it's important there because sometimes in a consultation with lots going on, they walk out and they forget that. So, another part of communication is written communication.
And that's what I was going to say too as well, not being defensive medico-legally, but how do you protect yourself from people saying, "Well, you never told me that," or "She never told me that"?
Yeah, I think I learnt a lot. I did a fellowship in Toronto, and therefore it's a slightly different culture there. So it's nice. I always advise trainees and fellows to try and get out of your immediate ecosystem. It's very common for trainees to train in a region, become a consultant in that region. That's great. You've got your infrastructure, your family there, but at some point try and go somewhere, even if it means you're going to another city in the UK, and ideally abroad, because you learn different things about different healthcare systems. And I think we do live in a time, particularly in ophthalmology, where you have to be aware of litigation.
Yeah.
I don't think it should be at the forefront of your mind, because I think that impedes good communication. If you're constantly thinking, "I don't want to say this," or, "I'm worried about this." But, I was talking about this at dinner with a colleague yesterday. What are the red flags when you are having a consultation? I think it comes a bit with experience.
Yeah, it comes a lot with intuition.
Mm.
But if you don't have that experience, it can be a little bit difficult to gain too as well, especially if you don't have any kind of peers or mentors to kind of work with. For our listeners, are there any strategies that you use when giving bad news or setting somebody up? Are there any kind of tips or techniques you tend to use yourself that you can pass on to?
I think getting the setting right. You don't want to be doing this in a noisy environment. So you want to go into a consultation room, maybe let the nurses know, "Look, I have an open door policy, but I may let the head nurse know who's on that clinic for the next 15 minutes. No interruptions on the door," and then he or she will patrol and make sure that one of my juniors is not coming in to ask a question. So ensure that the environment is there. Make sure that the patient is comfortable. And then really, there's no point sort of skirting around the issue. I think you just got to start there, because patients will often know. They'll know something's not right, and they're anxious anyway. So I just get straight into it and talk about it. As we talked about before, speaking in non-medical terms. There's nothing worse than bombarding them with results of scans or blood tests or MRIs or CT scans. Keep things simple, and then allow them to digest.
And ask any questions too as well.
Exactly. If they are tearful, allow them to have that emotional outpouring. It's an important part of their processing. And then once they are ready to engage in the consultation again, ask the questions. And you cannot rush that, because it's a life-changing moment in their life, and you have to appreciate that. And just because it's something that we do on a fairly regular occurrence, we should never belittle how important that is. And if it's handled badly, it can have significant repercussions.
I think everybody must be listened to as well, and that's the important thing, and treat everybody correctly. Going back to strategies and communication, do you use teach-back method?
I think teach-back is a good one, definitely. I think it's a really good way of reinforcing and making sure that they've understood what you've said. And I think when you hear it coming from their mouth, you feel a lot more confident that they have then actually listened to what you've said, because it's very easy for them to be nodding, but then they've just got the alarm bells going on in their head. So teach-back is definitely a good one.
And miscommunication tends to kind of be quite common too as well. So sometimes people just sit there and they nod their head and will say yes, 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 and then they walk out and say to the partner, "I don't know what he said. I don't know what she said."
And I think that's another good point. If you are breaking bad news and they are there with family members, do give them the opportunity for them to also be present there as well, because I think it can help set the tone, but also the more people that are there hearing it is, for me, only a good thing. So.
Yeah, and adds an extra set of ears and an extra set of memory too as well. And sometimes people, when they're with a consultant, do tend to kind of dry up and say, "Well, I don't think I'm allowed to ask questions." So sometimes that can be a problem too as well.
Yeah, and they feel a bit intimidated.
Yeah, of course.
I think hopefully that's not in my nature to be like that. But I think some consultation styles are a bit paternalistic, and some patients are in their nature quite passive. So maybe having someone else there that maybe can then take a bit more of an active role is only a good thing.
Going back to your journey too as well, do you find your journey, talking about paternalistic communication, do you find your journey maybe 10, 15, 20 years ago, the communication methods were different than they are today?
I think so. I think when I first started, it was a little bit more paternalistic. Doctor says this, patient does this.
Yeah.
That never sat well with me.
And that kind of hierarchical system was difficult to kind of, get used to.
Exactly. And both with doctor to patient relationship as well as within a team. I think it still exists in a lot of firms, maybe more in certain specialties. But I think with ophthalmology, where you're not going on big ward rounds with, the consultant at the front, fellow registrar, junior registrar, house officer, medical students. You see that in the hospital. They walk around and it's clearly, you can tell who's who. I think in ophthalmology where, maybe less ward-based activity does probably lend itself more to that sort of flat hierarchy. That's certainly something that fits better with me, but not to say that it doesn't exist maybe in some other firms and other ophthalmology departments.
Going back to your podcast, Gok, too, as well, do you use that platform to talk about communication and the importance of effective communication?
Yeah, thank you for that plug. Yeah, Outliers Insights, we've just finished season 1, and it's an important part. And I think for me, it's nice being interviewed this time round, and being the interviewer, it's really important because I've got a set of questions that I want to answer, but it never sticks to script, and that's part of the beauty of it. But you've got a limited time frame, and you want to get key points across. But I think what I've learnt a lot from doing the podcast is active listening.
For our listeners, would you be able to explain what active listening is in comparison to passive listening?
Yeah, with passive listening, you are quiet, but you're often thinking about obviously something else, but you're probably thinking about what you are going to say next. So you're almost pre-planning what your response is going to be to that conversation. Whereas active listening is where you are listening and you are fully engaged with what they're saying. And you know it. When someone's actively listening, you know that they're actively listening. When someone's passively listening, you can just pick up on that. And then with the active listening, what you then would say is going to be purely following on from what they've said. And it's a skill. I think it's a skill that I'm learning. And I think doing the podcast series has helped me a lot with that. And I think it's probably helped me with my communication with my team and my patients as well. So communication is not a skill that, you just master.
You can't read a chapter in a book and think, I've ticked that off. It's a lifelong skill.
Exactly.
But especially in a time-poor environment where we're under pressure too as well, and we can be busy and maybe kind of multitasking 2 or 3 things. And that's where passive listening can come across as being maybe, rude and arrogant, and they aren't giving me that 100%. But active listening is so important to be able to make the person feel relaxed and make the feel person that they've been listened to as well.
Yeah, and I completely agree. Ophthalmology is the busiest outpatients. There are a waiting room full of patients, but they have waited to come and see you. And it is our obligation to give every patient the time that they deserve. And, you cannot cut corners or time on that communication part. If you have to dictate your letters after the clinic, fine. Or, checking emails and things, do that afterwards. But when you're with the patient, make them the sole focus of your attention. And I think that would, a lot of the complaints, a lot of the angst when we do our friends and family feedback is not to do with the quality of care. I'm very proud of the quality of care that we deliver at Queen Victoria Hospital and the U Clinic. But any angst or the rare complaint could have been nipped in the bud with better communication, whether that's during the consultation, clinic letters, appointment letters beforehand, how the receptionist engages with them, all of those things. communication is such a broad
and
spectrum, and it's not just the moment the patient walks in and leaves the room.
Yeah, and it's
That's
not just you, and it's not just me as well, Gok. It's every person within the team and every touch point, from the phone call to the appointment setting to the arrival to the discharge, and then the kind of any engagement in between too as well. Anything can go wrong.
Absolutely.
What we're going to finish on is maybe for you to give all of our listeners maybe one or two top tips on communication. So maybe they haven't worked in ophthalmology, they're training at the moment, so they haven't really kind of had any retail experience, any kind of outward experience with people. What tips could you give them with regard to communication?
I think learning the skill of active listening is very important. Every time a patient were to come into your room, whether it's ophthalmology, optometry, or whatever warp of medicine or life it is, active listening will really help you get to the crux of what the problem is, as opposed to you call a patient in, you think you know what's going to go on. Allow that consultation to naturally evolve through active listening. And I think probably my second point or tip would be empathy. We are in the business of helping people with vision. It is the most precious sight. The overwhelming polls show that out of all the senses, vision is the one that people cherish and conversely are most afraid of loss. So, we are important parts of a patient's health journey and their vision journey, and the ability to be able to put yourselves in their shoes and go through difficult times with them, but also share great times. I get asked a lot, why did you become an ophthalmologist? Most of my patients, touch wood, are very happy. And when I can celebrate a good cataract surgery outcome or a good glaucoma surgery outcome or a good response to treatment, and we celebrate that together, that's great. And at the same time, when things aren't going well, you have to be able to then also, pull up your socks and be with them in that journey. And it can be quite emotionally draining.
Yeah, difficult.
And I think it's important to have things outside of work to allow you to reset, because you can take a lot of emotional baggage back home, and that's not great for family life and personal life as well.
And again, you don't get that life skill, you don't get that learning apart from experience, how to compartmentalize, how to be able to move on from a difficult episode, difficult communication. Again, do you have any tips for any maybe listeners who are kind of starting out? What can they do to end that kind of, journey, and rather than ruminate and carry on to the next day, just kind of draw a line in the sand?
Yeah, I think you just have to realize that sometimes in medicine, patients just get worse despite your best efforts. And, as long as you have done the best for your patient, then there's nothing more you can do. But I don't think there's any real tips or tricks. I think it's just taking time. I think it comes with experience. If I have a complication with surgery, I feel rotten. That evening, the days afterwards, I'm playing that surgical scenario in my head. Could I have done something better?
Yeah.
I record all my videos. I'll go back and just sit and watch that video again and be like, what's going on there? So I think probably spending that time to allow you to process it is important. But then you do have to move on. And particularly if you're doing, for example, a cataract list, if you've got a complication, you're feeling awful, but you've still got the next patient coming in there and they need your 110% attention.
Yeah.
So you've got no time to be feeling sorry for yourself.
Yeah.
You've got to get on with it and then do your best.
Yeah, I think from my personal scenario, how I learned is by mistakes. So when I made a mistake, I learned from it and kind of said, well, I'll try not to do that again.
Yeah, and that's a great point.
Yeah.
I think learning from mistakes is so important. Don't sweep it under the carpet. Don't go into denial mode and put your head under the sheets. Own up to it.
Yeah.
Learn from it.
Yeah.
And you will become better from it. Mistakes are a natural part of everyone's journey. But I feel one of the strongest determinants of those between those that are good, great, and the greatest are their ability to learn from their mistakes and improve.
Thank you much, Gok.
Thank you so much. It's been great. Enjoyed that.